Hello, class. Welcome. My name is Rick Page. It's really my pleasure to welcome you to the third course of our second year of mini med school. Just by show of hands, how many of you have been here before? Isn't that wonderful? Welcome. For the rest of you, welcome to freshman year. You've started kind of in the middle of the cycle. How many of you were here at the first one? Isn't that great? So you're finishing sophomore year. So when we make it, and we will continue, we continue to grow. When we reach 4 years, you do not get a medical degree. I'm awfully sorry. But you do become alumni. And as deans here from the mini med school, we love our alumni. Actually, after just showing up once, you're now an alum. So you know what that means to a dean. I am joined today in welcoming you by the other mini deans of mini med school. Real Dean Noma Anderson is Dean of the College of Nursing and Health Sciences. We'll hear from her in a moment. And better than Dean, Steve Leffler, President and Chief Operating Officer for UVM Medical Center here. And we're the ones who are responsible for mini med school, again, working with Ginger Lovkowitz with the foundation as we put this together. And what are we putting together here? This is an opportunity to share with the community some of the good things that are going on here at UVM, in the College of Nursing and Health Sciences, the Larner College of Medicine, the UVM Medical Center, and the UVM Health Network. We don't brag enough about the great things that we have here in Burlington. It's kind of the New England way, but we take this as an opportunity to share with you. So hopefully you will share with your friends in the community the good things that are happening here. And we focus on research, we focus on clinical care, and we focus on care to the community. And I don't know of a more timely topic than today's focus on mental health. Now, before I introduce the other deans, I do want to just mention that these are interesting times right now in higher education and in medicine. And funding is less secure in some ways than it's been in the past. Already we have had diversified funding, in part due to philanthropy from the community, people who have recognized that they wanted to invest here locally in the good things that are going on. And more than one or two of the faculty in the Department of Psychiatry actually hold endowed positions that allow them to continue their work with confidence that the money will be there to support them. So this is all about you, this is all about the community. And we're so glad you braved this weather. In the winter, we worry about the cold. We've never worried about the heat before, but we're really delighted that you're here. And now it's my pleasure to introduce my co-mini dean, Dean Noma Anderson.
Thank you for being here. As Rick introduces me, I'll repeat my name. I'm Noma Anderson, Dean of the College of Nursing and Health Sciences. And I join my fellow mini med school deans in welcoming you to this evening's course in psychiatry. As always, you will learn from faculty and researchers and clinicians who are doing inspiring work. With every mini med school, I welcome the opportunity to tell you about the College of Nursing and Health Sciences. Today, I want to highlight our undergraduate and graduate nursing programs. In the College of Nursing and Health Sciences, starting in the first year and continuing through graduate education, nursing students are educated to know that mental health is intrinsically linked to physical health. Nursing students acquire knowledge of the social drivers of health and are educated to look at the patient as a whole person. The ability and skill to assess patients' total needs is an integral part of nursing education at every level. In the undergraduate nursing program, students receive comprehensive didactic and clinical education in psychiatric nursing. Being here at UVM, the students have the high impact experience of engaging directly with patients at the Vermont State Hospital, as well as with patients at the UVM Medical Center inpatient psychiatric units. In the nurse practitioner program, these graduate students are educated to deal directly in a therapeutic and in a prescriptive manner with patients' mental health needs. And in terms of self care for the nurse, the College of Nursing and Health Sciences provides a Compassionate Care for Nurses course, which focuses on wellness strategies for emerging nurses. The College of Nursing and Health Sciences, the Larner College of Medicine, and the UVM Medical Center are fully committed to interprofessional collaboration that is so important to healthcare today. I am delighted to join my colleagues, Drs. Rick Page and Steve Leffler, and the amazing clinicians and researchers you will meet this evening. You'll learn a lot and you'll be inspired by the advances in psychiatric research, care, and education occurring at our institutions. Thank you.
Thank you, Dean Page. Thank you, Dean Anderson. They are real deans. I'm a fake dean. To be clear, I am not a dean. I'm an emergency physician. I'm a UVM Larner College of Medicine graduate from 1990, and I've been an emergency physician in this community for well over 30 years. And I'll tell you that for the vast majority of my career in the emergency department, we were ready to take care of people with heart attacks, strokes, car accidents, broken legs, cuts, fish hooks, things like that. When a psychiatric patient came in, we didn't really know what to do. For most of my career, we did our best to stabilize them if they had a medical problem. We could do that. And then the next step, we just didn't have a good plan for. Nothing bothers any doctor, but an ER doctor more than not having what's the next step to help this person get better, treat their problem, and have them not have to come back again. What you're going to hear tonight is really a fundamental change in our ability to care for people who show up with mental health crisis. As I said, even when I went to medical school, we really focused on people's physical health, but it turns out your mental health plays a giant, overwhelming role in your physical health. You're going to hear great information tonight about how we're embedding psychiatric services in our primary care offices. We have psychiatrists in our ED now. We have it in our schools across the state. It's making a giant difference now, but down the road, the impact is going to be even greater. So I'm so excited for what we have here tonight, and there's even more coming. I'll tell you now that in my role, I'm not really doing much emergency medicine now, but now I have to figure out how we afford and pay for all this in the hospital, and I'm sure you're seeing there's a lot of challenges right now. The honest truth is, for all of medical, the last 30 years, psychiatric care isn't valued at the value it provides to the patients, meaning what the reimbursement is from insurance companies, from Medicare, isn't covered. In Vermont, we've been lucky, we've been able to cover some of that through philanthropy. Thank you. We need that. It's so important. But once again, we're learning now that if you have untreated depression or anxiety, your true healthcare costs double or triple. Okay, you show up in the ER more with chest pain, it's not heart pain because you're anxious. You have depression, you're not taking good care of yourself, you're not taking your medicines. So I'm so excited for you guys to hear the amazing work going on in Vermont right now. There's even more coming. You're gonna love these talks, I know that. We're gonna hand out cards to all of you and write down questions, stump your professors. That's what you get to do at the end. And then also afterwards, we typically hang around out there. The experts will be here to answer your questions. So make sure you save some questions, but write them on the cards. We'll answer them after they're done speaking, and then we'll have a nice reception. So with that, I think Dean Page is coming back up to get us going. Thank you all.
Thanks, Dr. Leffler. Each time we have mini med, it's around a theme, and we have a course director, and I have the pleasure of introducing our course director in just a moment. I will make note of the fact that for each of these events, for each class, if you will, the course director works directly with us as we come up with really a dream team of clinicians, scientists, healthcare specialists to put together an evening that really educates you in the full spectrum of the matter at hand. And that's what we've done for you today. I'll also mention that it's not typical of doctors, researchers to have rehearsals. And we actually have a rehearsal. We sit together and show each other the slides in an effort to make this as user-friendly to those of you in the community. So I do want to thank in advance all the work that went into this process through the leadership of Dr. Rob Altoff, our course director. Dr. Altoff is a national leader in child and adolescent psychiatry, specializing in research on the development of emotional self-regulation in children. He's a distinguished fellow of the American Academy of Child and Adolescent Psychiatry and associate editor of the Journal of the American Academy of Child and Adolescent Psychiatry. He's been on the University of Vermont faculty and part of the UVM medical group since 2006. In 2022, he was named chair of the Department of Psychiatry and became health service leader for UVM Health Network in Psychiatry. He teaches undergraduate, graduate, and medical students along with residents and fellows, and mentors PhD students in his laboratory. And he's received the Excellence in Academic Teaching Award from the UVM Psychiatry Residency Program, not just once, but twice. He's served at various partner organizations within UVM Health Network clinically. So taking care of patients at the Champlain Valley Physicians Hospital in Plattsburgh, Porter Medical Center in Middlebury, Central Vermont Medical Center in Berlin, Alice Hyde Medical Center in Malone, and of course here at UVM Medical Center. He also serves as Executive Vice President of UVM Vermont Center for Children, Youth, and Families. He earned his medical degree at the University of Illinois College of Medicine and a PhD from the University of Illinois, Champaign-Urbana. And then he completed internship and residency at the University of Washington, first in pediatric and child neurology. He didn't get enough at that point, and then took a residency in psychiatry here at the University of Vermont. And even that was not enough for Dr. Altoff, who went down for a fellowship in child and adolescent psychiatry at the Mass General Hospital and McLean Hospitals before returning here at UVM, and we're so lucky to have him here. Please join me in welcoming your course director, Dr. Rob Altoff.
Thank you, Dean Page. Yeah, my mother would appreciate you walking us through that long educational history. Thank you. So thank you, Dean Page, Dean Anderson, fake Dean Leffler. Good evening to you all. I'm so pleased to offer my own welcome to you this evening of advancing mental health through science, community, and collaboration. As chair of the Department of Psychiatry at the Larner College of Medicine and the UVM Health Network, I have the great pleasure of serving as your course director tonight. I also have the great pleasure of sitting through most of the talk, so I don't have to be up here speaking most of the time. So I appreciate that. Thank you. It's never been more important than right now to be knowledgeable about mental health. Leading into the pandemic, we had increasing numbers of individuals seeking services. Coming out of the pandemic, those numbers have only increased. Perhaps as importantly, the data show that our mental health, our behaviors, and the social circumstances in which we live are actually contributing more to decreasing our lifespan than pretty much anything else we do in medicine, and more than even our genetics. Despite how central mental health is, we're still experiencing a crisis. And that crisis in mental health and substance use care is mostly because the gap between the need and the access has been increasing. People need the services now more than they ever had, and yet it's harder and harder to get them. We have to develop new ways to understand, to treat, and to care for the people. And as you'll hear, as our speakers talk, The reason for that is because very few of us, I would say almost none of us, are untouched by mental health and substance use. In our department, we share the mission that together we will advance the understanding and promotion of mental health and well-being in our communities through advocacy, education, research, scholarship, and compassionate, high-quality clinical care. We're going to showcase some of that tonight. When we consider the breadth of the concerns, it's hard not to feel like it would be impossible to make a difference in the grand scope. And in fact, one of the most common questions I'm asked is, how can one person make a difference? And every time I hear that, I, of course, think about Elvis. But what I really think about is Elvis impersonators. I think about Elvis, they actually prefer to be called Elvis tribute artists. So I think about Elvis tribute artists, and here's why I think about that. In 1977, when Elvis Presley died, there were 177 registered Elvis tribute artists. In 2011, the last time reliable data were obtained, there were 85,000 registered Elvis tribute artists, 85,000. Now, if you do the math, and I did, you could calculate a curve to suggest that by the year 2075, less than 100 years after the death of Elvis, the entire world will be populated by Elvis impersonators. Now, of course, that's ridiculous, but it does lead you to believe, what is it about a person, one person in the world, that can make such a profound difference that 85,000 people or more would decide to follow this person's lead? And there are lots of reasons, of course, but probably the most important one was he's in the right place at the right time, and he had the right skills. And so that's what we try to do in our department. We try to be the right people at the right time with the right skills. And in doing that, I think that you can be a rock star. And so that's what I did. I brought 4 rock stars tonight. I decided to bring 4 of my rock stars in the department. These faculty will provide an idea of the depth and breadth of the research and clinical programs we offer to Vermont, New York, the nation, and the world. These efforts are pushing us towards our departmental shared vision of thriving communities with improved mental health and access to state-of-the-art care. Our department believes that through our shared values of compassion, humility, fairness, and curiosity, we can get there. And I think you'll see all of that tonight. Because at the core, we believe that mental health is the core, is the basis of all health. So for that reason, I wanted to make sure that we highlight the various areas you're going to hear about tonight. Now, I'm sure you're all excited to hear about this work. Don't want me to keep rambling on, so I'm going to get right to our first presenter. To start, I'd like to introduce Dr. Masha Ivanova. Dr. Ivanova is Associate Professor of Psychiatry and President of the Research Center for Children, Youth, and Families. She received her PhD in clinical psychology from the University of Albany, completed her postdoctoral training into developmental psychopathology at UVM. Her research aims to understand how environmental factors shape mental health and well-being across the lifespan. Dr. Ivanova's contributions include demonstrating the way that mental illness is expressed across cultures, developing a family-based therapeutic assessment and feedback intervention, and co-developing a comprehensive family intervention that improves health outcomes by helping parents to embrace and enhance health-promoting family routines. Dr. Ivanova.
Thank you so much, Dr. Alder, for demonstrating the power of the scientific method in estimating population trends. That was a surprising gem of your introduction. Thank you. Thank you to the deans. Most of all, thank you so much for coming here today. I am thrilled to have an opportunity to tell you about my work, frankly, because my family is tired of listening to me talk about it. So every time, one second. So when we have an opportunity to share what we do, it is an immense privilege, and I am so grateful. So again, my name is Masha Ivanova, and I study, I do population research in psychiatry. So sort of like high-level population research. And by the end of my short talk, I hope to show you that population research in psychiatry can reflect some fascinating aspects about what it's like to be human. And I will do my talk by, one second, let me just get used to forwarding. Okay. I will do my talk by sharing a few little gems from research by professors in our department, in our psychiatry department, and some of my research that I think provide some fascinating perspectives on our humanity. So first, kindly allow me to introduce you to Professor William Copeland, who is the Thomas Achenbach Endowed Chair in Developmental Psychopathology in our department. And he's also principal investigator of a prospective cohort study in the Great Smoky Mountains. So it's a group of families who are being followed for a few decades. And a few years ago, Dr. Copeland asked an essential question, which was, how rare are considerable significant psychiatric problems? And he meant, how rare are psychiatric disorders, DSM psychiatric disorders? So we think of them as something that occurs quite rarely, as maybe affecting a few people in our communities or in our families. I'm talking about really impairing conditions. If you would kindly bring your attention to the last bar of the figure in the middle of the slide. This figure presents cumulative prevalence rates of any psychiatric disorder for children and adolescents in the cohort that Dr. Copeland has been following between the ages of 9 and 21. And a cumulative prevalence rate, it's when you take time 1 rate, add time 2 rate, time 3, and et cetera. So it's just an additive rate. So as you can see in the last bar, by the time the kids in this cohort reached age 21, 4 out of 5 of them had experienced a significant and impairing psychiatric disorder. And that's just by age 21. So if you extend that follow-up period, you can just presume that, well, most kids in this cohort, and really most of us, frankly, will experience significant impairing psychiatric conditions as we move through our lifetimes. And now kindly allow me to introduce you to another professor, the late Dr. Thomas Achenbach. He was a revolutionary, transformative clinical psychologist in our department, and he really changed the way we think about emotional behavioral problems. So he asked another essential question, which was, what is the best way to classify mental health problems? Why is this important? Well, as I'm illustrating the left side of the slide, any self-respecting discipline strives to understand the subject matter, describe it accurately. What is in front of us? How is it carved at its joints? And psychiatry is no exception. We need to give clinicians guidelines for recognizing significant psychiatric conditions. We need to facilitate communication between different professionals. And we need to organize our scientific efforts, our educational efforts. So it's important. And Tom went about it in a sort of simple way, but in retrospect, an absolutely brilliant way. So he started this work at the end of last century, and this is how he conducted it. And bear with me, we're getting to somewhere exciting. Okay, so he took a large group of people, so large representative sample of United States children and then adults, and he asked them questions about a broad range of their emotional behavioral experiences in the same way. So essentially, he asked them about psychiatric symptoms. So how anxious do you typically feel? How sad do you typically feel? How hard it is for you to sustain attention in certain circumstances, et cetera, et cetera. So really a broad range of symptoms. And then he took that cloud of data, so thousands of people reporting in the same way about their experiences, and he asked essentially statistics or data analysis to tell him, what is the underlying structure of these data? Or how do symptoms, psychiatric symptoms, occur in the real world, in the real population? Oh, so imagine, so we have thousands of people answering questions about hundreds of experiences that are discrete and describable and mostly observable. So there are almost an infinite number of ways in which the symptoms can form clusters or arrange into those units of classification, right? But no matter how the question was asked, out came these mysterious groupings of symptoms. And I invite you to kind of peruse the titles that are embedded in the ovals. Essentially, these hundreds of items or hundreds of psychiatric symptoms found their way in 8 buckets of all the thousands of ways in which they could have arranged. The titles within these ovals are just descriptors. They basically literally tell you what kind of psychiatric symptoms find themselves into these buckets. And an important little nugget here that we will play with a little bit later is that the first three groupings, anxious, depressed, withdrawn, depressed, somatic complaints, and the last two groupings, rule-breaking behavior and aggressive behavior, also form these additional groupings, or they occur together in the population. So if I'm likely to have a higher level of anxious depression, I'm also more likely to have a higher level of withdrawn depression. So they just co-occur, and this will come a little later. And when this was discovered, Tom began discovering this in different samples, males, females, older, younger, children, younger adults, older adults. So these groupings, these 8 buckets, it became apparent that they can be used as a research-based classification system to make sense of how emotional and behavioral data, or how emotional behavioral experiences are carved at their joints. I'm getting somewhere fun. Hold on. Okay, so this slide summarizes 15 or 17 years of my life. So I interviewed with Tom and said, well, Dr. Achenbach, I'm a recent immigrant from another country. And what I have some problem with is that you're arguing that this model can be applied to everyone around the world. And here's another example of maybe a Western model being applied to very diverse people. And he said, he was a very sort of stoic, reserved man, and he said, well, you seem to be really interested in this question, so why don't you go ahead and study it? And so for the next 15, 17 years, I asked the question of, what is the extent to which our 8 friends, or these 8 groupings of psychiatric symptoms that were found in all kinds of ways in the United States, can they explain the structure of emotional and behavioral health for people of diverse backgrounds? And my voice is a little shaky because I feel like this is an especially important slide to talk about, this week or at this time, because no matter how we ask this question, the question was, how well does this 8 grouping model describe the organization or the structure of data in these societies? The answer was invariably yes. So if you would kindly glance at the types of societies that are represented on this list, they vary so widely in all kinds of ways that you think should impact the emergence and organizational of emotional and behavioral health around the world. There's studies varying in political systems, educational systems, approaches to gender roles, approaches to parenting, all these massive ways in which people in these societies differ. But study after study, paper after paper, we found that our 8 friends actually accurately, robustly, consistently describe the structure of emotional behavioral health for people of these different backgrounds, suggesting that we're all the same species, that we're all human beings around the world, and that our emotional behavioral or psychiatric distress is organized in a very similar way. But you might say, well, Masha, this is sort of interesting, maybe relevant somewhat, but does this help anyone? Does this alleviate anyone's suffering? And it was very important to Tom to develop an assessment system or a set of clinical tools for clinicians based on these on learnings from this research. So specifically, he developed standardized questionnaires. Some of you are nodding. I know that you've probably painfully used them before. He developed standardized questionnaires to assess these symptoms, and then some software to provide clinicians with benchmarks, signaling or anchoring the elevation of problems they saw in front of them. So just to give you an analogy, when we bring our kids to the pediatrician's office, the pediatrician would measure their height and weight and use these indices as clinical constructs about which she can make sense of our child's physical development. And then she would plot these, recognize these? And then she would plot the data based on these charts that signal back the elevation of the scene scores based on population reference points. The higher, the more elevated. Well, very similarly, we can take these robust 8 groupings and use them as clinical constructs that could help us conceptualize individual differences in how people experience their emotional and behavioral health. So here I am giving you sort of a simplified version of the output that a software can present. The 8 syndromes or groupings are listed on the x-axis, and then the normative benchmarks or population levels could be signaled on the y-axis. I'm just simplifying it. And here's a really interesting thing. Each of us experiences a set of symptoms in response to stress. And these symptoms vary from person to person. So we've learned that these profiles or these peaks and valleys of emotional behavioral experiences are really clinically helpful ways to make sense of the individual differences in our patients. We all have a little bit of something on these profiles. This profile can be applied to each and one of you, and myself including. These profiles are stable over time. By the time we arrive in our mid-childhood, we already have arrived at our profile. And all of these relative elevations have their strengths and their difficulties. So to give you an example, if I am, and this is a true story, if I am likely to experience higher levels of anxiety and depression in comparison to population levels, the flip side of that is, oh, I'm allowed to say very favorable things about myself, but people who are likely to have higher levels of anxiety and depression are more sensitive, more attuned to others. So each of these elevations has an advantage and a disadvantage. And now I encourage you to perhaps apply them to yourself privately. You know, we don't need to know these private details about you, but what does your nervous system do under stress? Where do you find yourself on these profiles? Are you the kind of person who experiences more internalizing difficulties? So maybe some anxiety, some depression, some withdrawal when you're stressed out? Are you the kind of person who experiences more externalizing difficulties? So maybe by that I mean the last 2 groupings of rule-breaking behavior and aggressive behavior. And the difference in the population among all of us to be one way versus the other is a very enduring, consistent kind of population finding. Well, let's do a little experiment. How many of you sort of identifies with an internalizing profile or propensity to experience anxiety and depression under stress? Okay, let's do the opposite. What about externalizing? So are there any people here who, when you're stressed out, you kind of get a little bit hot and you want to push against boundaries, push against social norms and get your own back? How many of you? Oh, interesting. Thank you so much. I was going to make the point that we typically see women leaning more to the internalizing side and males leaning more to the externalizing side. But you've disrupted my hypothesis. And there was, and then this is the final piece of data, and then I'll just summarize. So here's another really fascinating, very recent finding from population research about kids and families who come through our door in the clinic. So because we were socialized by Tom's work, when we assess the little ones who come through our clinic, we assess them using the 8 groupings or the 8 friends. We assess not only the child, but also the parents. So we are ending up with a beautiful repository of data using the same constructs to make sense of both children and families. And we are finding that if you have a little nugget who comes through our clinic door and she's experiencing any type of problem as captured by these profiles, and I'm presenting these data as internalizing versus externalizing for data types in the table. So if she's presenting any type of this problem, there's going to be at least one adult in her environment who has the same type of problem. Moreover, and the following finding is even stronger, if you take any family, and if there's one person, one adult in that family who is experiencing a particular type of problem as captured by these groupings, there's a really, really high likelihood that there's going to be another person, another caregiver in that family experiencing the same type of problems, suggesting that there's something familial about the nature of emotional behavioral health. Our mental health difficulties aggregate in families, so we must augment how we treat them with family-based perspectives. Okay, quick summary. I may be a little bit over my time. So Dr. Copeland's work has shown to us that mental health conditions are a nearly universal experience. Remember, 4 out of 5 kids experience significant psychiatric problems by the time they were 21. Dr. Achenbach's research that I based my research on has shown that despite our tremendous perceived differences around the world, we experience and express our emotional behavioral difficulties in very similar ways. I've tried to make a point, though I don't know if I succeeded, that understanding our own profiles with regards to those 8 groupings or our 8 friends can be really helpful because those profiles are stable, they're with us all of our lives, and because there are advantages and disadvantages to every elevation. So if you know what your peaks and valleys are, or Dean Page, this is for you, what your emotional EKG is like, then you're likely to learn strategies to minimize the cost of your elevations and to boost the gifts that are the flip side of them. And finally, and this is fresh off the presses, we analyzed these data 3 weeks ago, we have this unique repository of data in our clinic that is allowing us to finally articulate in an empirical way that mental health conditions cluster or aggregate in families, so we must treat them in that way. Thank you so much.
Thank you, Dr. Ivanova. I'd next like to introduce Dr. Alexi Potter. Dr. Potter is a professor in the departments of psychiatry and psychological sciences at UVM. She's a licensed clinical psychologist with over 20 years of experience working with families in Vermont. Dr. Potter completed her PhD and postdoctoral training at UVM, joining the faculty in 2003. Her scientific career is centered on using brain imaging and behavioral methods to investigate individual differences in vulnerability to addiction, developmental conditions, cognition, gender development, and behavior. She's embraced a scientific shift towards big data to better identify and characterize individual differences in brain development, and she and Hugh Garavan are the site principal investigators for 2 large NIH-funded trials of health and development that you'll hear about. She's been recognized for her leadership within these national consortia and for her commitment to mentoring the next generation of neuroimaging researchers. Dr. Potter.
All right, thank you, Rob. Thank you, Deans, for putting this together for us, and thank you to all of you for coming. Really is a pleasure for me to get a chance to talk to you about some of the research that we're doing in my lab. And Rick says we don't brag enough. I'm going to try to not brag too much because we have some really exciting things happening in my world. What I'm going to talk to you about tonight, first, I'm going to start talking about this shift we've had in understanding the brain to a population level. So that'll be the framework for why we're studying these large data sets. And then I'm going to tell you about 2 big trials that we're a part of here at UVM. And these are studies that are really fundamentally shaping the landscape of how we study brains and development all the way from birth through adolescence and early adulthood. So when I began doing brain imaging research, it was in the early days. MRI research has only been around for, 30, 40 years anyway. And what we used to do is to say, I wonder what depression looks like in the brain. And we would take 10 people who are depressed and 10 people who were not depressed, and we would compare the pictures. And the field went along that way. It was actually really easy to recruit participants, right, and get your studies done. But what we found out is that those findings didn't replicate. Someone else would take 10 people and find something different. And our field kind of went through this crisis to say, we're not actually defining the ground truth. We're kind of trying to figure out some things, but we're really having trouble understanding that. And in order to actually understand these fundamental things about how brains develop, we have to understand them within the context they occur. So you have kids who live in families, who live in communities, who live in societies. And if you're not accounting for a lot of these things, you're not going to be able to get to the ground truth. And so what happened is this shift towards bringing a population perspective to neuroscience and trying to leverage the tools that we have using brain imaging together with the tools from population sciences. And when I talk about population sciences, Masha just gave you a great example of how behavior was studied in a population way. Brain imaging, now Masha also flashed up a picture that was a growth chart, and brain imaging, what we know is that there is no growth chart for brain imaging. So when you go to the pediatrician, you can have your kids' height and weight charted and see what percentile they are at and what the trajectory will likely look at. We have no way to know that about what your frontal lobe should look like or how big your amygdala should be at a given age. So we're really lacking that fundamental knowledge. Well, this problem was really recognized by this woman here. This is Dr. Nora Volkow. She is the director of the National Institutes of Drug Abuse. And she really was one of the first people to really articulate this problem and to really invest her career in a solution. And basically, she was interested in how people develop addiction. And what she said is it's really difficult to disentangle the effects of early exposures and how they interact with each other and with people's genes. And our understanding is really limited because there's not enough research on normal brain development in very large samples to take us from birth through adolescence in order to answer these fundamental questions. And so what she did was lead the effort for these two large studies. First, the adolescent brain and cognitive development study began in 2015. And I will tell you a little bit about that in a second. And then shortly after, with shortly in my world, in 2022, we launched the Healthy Brain Child Development Study, studying people from their second trimester of pregnancy until those children are 10 years old. Both of these studies use repeated brain imaging over time so we can actually start to map out these trajectories. And the idea here is that these studies were created to answer the most pressing public health questions of our day, and they can dramatically advance the science and have immediate and substantial implications for healthcare practice and policy. Because if we want to know how somebody gets to be who they are, if we can understand what things fundamentally shape how their brains work and how these connections are made in their brains, we have a much better chance of identifying early who they are, what those trajectories look like, and being able to provide services. So the ABCD study is funded by NIH. We began enrolling participants across a consortium of 21 sites, and UVM is one of those sites. We began in 2015. And in 2 years, we enrolled 11,878 youth. All of the kids were 9 or 10 when they entered the study. And we've been following them now for about 8 years. UVM has a cohort of 575 families. And actually, when we wrote our grant it was a competitive process to get to be a site for ABCD, our proposal meant that we would have to recruit 6% of all 9 and 10-year-olds in the entire state of Vermont. We were like, I don't know if that's doable, but we'll try. And we hit our target. We have as many as all the other sites in the consortium. And the reason why is because Vermonters live in really strong communities. So we did our recruitment in schools across the whole consortium. We decided to do our recruitment in schools. And what happened as schools were very happy to have us come in and provide some brain education. And as one person signed up, they talked to a friend who signed up, and a parent talked to their little league coach who then had their kids sign up. And we really had this kind of snowball effect of recruitment and have built this incredibly strong cohort of families in the ABCD study. And really surprisingly, at the 7-year mark of follow-up across the entire consortium, we have over 95% of those families still contributing data. In our world, that number is usually about half of that. But this study, I think, is an exciting study. People committed a lot of time to join it, and people are continuing to give us their time and to help us study things. When people come in for study visits, they are long visits. The initial assessment took about 8 hours. It includes a brain imaging scan that takes about an hour and a half and looks at how your brain is structured, the sizes of different areas of your brain. We map your brain during you doing tasks, so we can see what part of your brain do you use to stop an impulsive behavior. What part of your brain lights up when I tell you you might win $10 on this next game if you're really fast at responding? What part of your brain is used when you're trying to remember words that I'm going to ask you to recall later? And so we have that data at all the different time points. We also have an extensive amount of other data. We collect biospecimens from all of the people. So we have genetic and hormone data on everyone, detailed measures of cognition, of mental health. In fact, we use the measures that Tom Achenbach and Masha developed, and those have been incredibly valuable, and so much more. And one of the things that Nora Volkow, the director of NIDA, was so committed to and has been really incredible was the idea that we would do this in open science, meaning all of the data is publicly available to anyone who signs a data use agreement about treating that data confidentiality and analyzing it responsibly. But it means that people who don't have the ability to collect this type of data have the ability to analyze and publish this type of data. And it means that scientists who were not particularly interested perhaps in substance use and addiction can publish studies. One of the very first studies that came out was from a group of dentists who used the MRI scans to look at the structure of the jaw and the teeth in 9 and 10-year-olds and had a bigger data set than they had ever had before, published a real seminal paper in that. So having that open access to data is really great. By doing this study, what we hope is to answer these very fundamental questions. How does your brain, genetics, experiences, and environment affect your behavior and affect your development? How important are all these things like nutrition, sleep, screen time, your friends, whether you tried drugs, whether you're involved in sports or other activities, what your family life is like, your physical health, the community factors around you. So we have thousands of variables of all of these things measured over time. And then are there different patterns of brain development that will help us understand differences in outcomes for these children? And this is something I'm particularly interested in. So what I'm showing you here is an analysis that we have done in our lab looking at brain maturation in the ABCD study over time. So the brains on your right there are scrolling through a series of months that are the age. So that starts here in this kind of red. As it gets blue, what's happening is your cortex is getting thinner. So when you are 9 to 10, you have all of your neurons. And what happens in the next decade of life is that you prune the ones you don't need, and the ones that you are using are staying really strong. And so what you'll see is as the blue is developing, where it's getting thinner, it's at different rates across different parts of the brain. So for the first time, we're able to start to put together these charts that say, about how thick should your cortex be right here when you're 10? How about when you're 14? How about when you're 18? And now we can take that data and see, is this different for kids who have ADHD and don't? Is it different for kids who play sports or don't? Kids who have head injuries or don't? And you can imagine all of the types of questions that you can answer with this data. But of course, your brain doesn't start developing at 9 and 10. It starts even before you're born. So what this figure here on the left is showing you a brain in utero. So the bar at the top is going from 0 to 40 weeks. 40 weeks is full gestation when children are typically born. What you'll see is the brain starts small and pretty smooth. And as it grows, you can see the shape changes. Not only does it get bigger, but you also start to get that those peaks and valleys and those gyri and sulci in there as your brain is developing. And we think just like your brain, as those neurons are pruning, that this growth has also follows a predictable pattern that we can measure. So the HBCD study is designed to measure babies from when they are young until they are 10 years old. And UVM is also a data collection site for this study. This is the study enrolling 7,500 pregnant people. We'll follow them for 10 years. There are multiple brain images in the first years of life. On the right-hand side, that top picture is a baby here at UVM being scanned at 26 hours old. So we are incredibly lucky and unique at our site that when people deliver their babies, if they want, they can do that first scan before they leave because our research scanner is located in the same building. Not all sites have that. And then people in Vermont in February don't have to come in the first 30 days of life to get their scan because we already got it when they are here. But that is a baby we scanned there. And right below is that baby's brain. And I will say that I've, having done hundreds and hundreds of scans, it never loses the thrill of you turn on the scanner and you get that first image and being able to see that baby's brain in real time. Just a little bit about the HBCD study. I'll take you through pretty quickly. Before babies are born, you get a very intense assessment of demographics of the maternal mental health, substance use, protective factors in the environment, family factors, those things. In the first month of life, we have that first MRI. We also are getting growth measures like length, weight, head circumference, those types of things. This study, we have some pretty incredible biosensor data. So on the far right-hand side, that band that's on that baby's arm is actually measuring heart rate and heart rate variability, measuring it continually for 3 days, while they're also wearing these super cute little leg warmers you'll see in the middle. Those each contain a little square sensor in them that is actually an actigraph, just like your Fitbit or your watch if you have them, and measures how much those babies are kicking their legs. It measures the synchronicity with which they kick their legs. You can tell when they're awake or asleep there. And so we get that data twice in the study as well to look at that very early movement and what that means. As babies get older, we're employing some other really cool technology. On the far right-hand side there is a baby that is taking a cognitive test, looking at really early development of language, memory, and numeracy. And they are looking at this iPad that's actually tracking their eyes, and the computer will say, "Where is the dog? Look at the dog." And even a little baby, when they hear the word, if they know what it means, will preferentially look. And the way the iPad actually scores where your eye gaze is. Are you looking at the dog or are you looking at that tree over there? And so it actually can measure that. And I, along with my colleague Julie Cable at Emory, oversee this for the entire consortium. So we develop all of the measures of language and cognition that are being used, train all the research staff. We've created a team to do all of the certifying people to do these tests. Been very fun. We also look at caregiver-child interactions and code their faces to see, as parents and infants talk together, they usually match each other and mimic, and there's some good data that how attuned they are to each other will predict how things are going to go over the next few years. And so we're getting that data as well when those children are really little. Now I'm going to switch here and say, we talk about communities and what is the motivation for a lot of this research? I'll tell you, it's, a lot of work running these teams and collecting these data. And part of my motivation is this child that you see here. This is my daughter, Demetra, from the moment she was born and through her life where she is now on that far right-hand side, 29 years old. She spent a month whitewater rafting through the Grand Canyon this winter. And I think about, how did she get there? How did she get from this tiny child to this adult? And she's had many ups and downs in her own life. And these are the motivations that you think, how does this happen? And how can we best support these kids? And the data that we are collecting is really the first time we have an opportunity to start to answer some of those questions. And it takes a village to run these studies. So I want to give one big shout out to Hugh Garavan on the top left there. He is my partner in crime. We run a big lab together, running both of these studies and doing all of this work. You have a lot of our faculty on there. These two women on the bottom left, one of each runs one of these big studies. It is an incredible amount of coordination to do that. A bunch of our research staff there on the right. And I will say, as we were told, we were allowed to brag that ABCD and HBCD are not run at the same institutions. It was a competitive process, and they are completely independent grants. UVM is one of 3 places that is able to do both of these studies, that houses them both. And our Department of Psychiatry with Hugh Garavan and I are the only PIs in the country that are running both of these studies. And it's because we have an incredible imaging center that we can access. We have an incredible advanced computing center that can do our data analysis. So I feel incredibly lucky to be at UVM and to be in our Department of Psychiatry. Thank you.
Thank you so much, Alexia. To look more at the outcomes and management of folks for risk for substance use disorder, it's my pleasure to introduce Dr. Steve Higgins. Stephen Higgins is a University Distinguished Professor, the highest distinction for faculty at UVM, and the Virginia H. Donaldson Professor in Translational Science in the Departments of Psychiatry and Psychological Science. Dr. Higgins directs the Vermont Center on Behavior and Health, an NIH-supported research center focused on the influence of lifestyle on risk for chronic disease and premature death. He's held many national scientific leadership positions, including terms as president of the College on Problems of Drug Dependence and the American Psychological Association Division on Psychopharmacology and Substance Use. He's received numerous national awards for research excellence. He's the author of more than 450 journal articles, invited book chapters, and edited volumes, and therapist manuals in behavior and health. I said rock star, and I meant it. Dr. Higgins.
See how this works, is standing out. Good. So yeah, thanks for that nice introduction, Rob, and thanks to all of you for being here, and I'm really pleased to be part of this event. So I direct the Vermont Center on Behavior and Health, and that's an NIH-supported center focused on how lifestyle can increase risk for chronic disease and premature death. So I want to start with some background. US population health is far worse than other developed nations, despite spending gobs more money on healthcare than any other developed country. So unhealthy behavior patterns, lifestyle. So when population health experts see this, they ask the question, well, what's the source? Why is this the case? And what they come up with, it's about unhealthy behavior patterns or lifestyle. And so that can sound a little abstract, but not so much when you look at that third bullet. Oh, I had a feeling that would happen with this pointer that has. So this third bullet here, it's tobacco use. Cigarette smoking remains the single biggest preventable cause of death in the United States, 450,000 people a year. And then other substance misuse, obesity, physical inactivity, poor adherence to preventive medical regimens, think colonoscopies, those things. So these healthy lifestyle choices are generally challenging for all of us. We all make them every day. But if you have a disability, if you reside in a rural community where you can't easily access a healthcare center, if you're a member of a minority, lots of other factors influence your choice. And so this is what leads to health disparities. There are certain subgroups who are suffering more from these chronic conditions than other groups. And so what we try and do is understand it and see if we can improve the situation. Oh, so now, all right, so I want to show you some data on US population health. So this data comes from the Commonwealth Fund and that's a nonprofit organization that studies health policy. And I'm going to start off with this graph is showing on the axis here is the percent of the gross domestic product that a country devotes to healthcare, and then down here years. And these are all the developed countries in the world. And we're up here and everybody else is down there in terms of how much we're spending on healthcare. So now they have certain metrics that they look at, these population health experts, to discern how healthy a population is. And it makes a lot of sense. They start with longevity. So this is years, how on average, how long do people live in these different countries across time. We're this guy over here. And in fact, for the first time around 2015, longevity in the United States turned over and start decreasing by year rather than the typical pattern earlier of increasing. All right, another metric they use is infant mortality, surviving the first year of life, and maternal mortality, dying in pregnancy. So the way these graphs are shown, the countries are down here on this horizontal axis, and then the bar graphs are the most recent data they had on it. US is the green bar on both sides, so we have more infant death in the first year of life than any other developed country, and we have more deaths during pregnancy than any other developed country. So you can see why the NIH is interested in supporting centers to try and understand this better and do something about it. So what I have here are just 6 examples of in a wide range of topics that we investigate in the center. Start with this one on top is certain biases that individuals have and how they make decisions can increase risk for making unhealthy choices. And there's a whole range. You can see tobacco, I already mentioned the terrible impact of cigarette smoking on US population health. And the one I want to focus on going forward here is incentivizing behavior change, because that's the area of our center that I lead myself. So I know it better, and I'm going to talk to you about it. All right, so back in the 1990s, our group demonstrated that providing small financial incentives, they were vouchers redeemable for retail items, can increase healthy choices in otherwise treatment recalcitrant populations. So some of you might remember back in the mid-1980s, early 1990s, we had a cocaine epidemic in the United States that was much like the opioid epidemic that we currently have.